everybody. It's an honor and privilege to be presenting for you today on a topic I care a lot about. I had the opportunity to present to your group about a year and a half ago, and it was a real highlight for me, and I was honored to be invited back. My name is Cody Wyles. I'm currently a chief resident in orthopedic surgery here at Mayo Clinic. I'm also an assistant professor in the Department of Clinical Anatomy. And today I'll be talking to you about hip and knee replacement, which is my intended area of expertise, and really what you should know if your joints are wearing out and in need of an upgrade. So without further ado, we will get started. So why consider getting a joint replacement? Well, there are two primary reasons to consider. The first is always to reduce pain. That is the main reason we do this type of procedure, these operations for hip and knee arthritis. And we operate on pain, not x-rays. So that is a theme you'll hear coming up over and over again throughout this talk. The second reason to get a joint replacement is to increase function. Of the two, I would call that the more secondary reason, but they go hand in hand, and usually we're doing it for both reasons. Now, people that get a joint replacement typically have degenerative joint disease. That is the case for over 90% of all patients that get a joint replacement, and osteoarthritis, or more commonly arthritis, is the main reason for that. There are other reasons to get a joint replacement, and the second most common reason would be trauma. So you or a friend may have had a hip fracture or know somebody that had a hip fracture, and that is another common reason specifically for the hip, where we will address them with a joint replacement. Now, when we talk about how we see patients in the clinic and what signs they present with, patients with hip osteoarthritis will have pain in the groin region and or the buttock region. Those are the two most common locations and really the areas that kind of tip us off to think that this is coming from inside the hip joint. You see this patient on the left is pointing with what we classically call the C sign, as their hand is making a C shape, pointing to their groin and their buttock as the area where they are experiencing that pain. Now, this is to be differentiated from pain on the side of your hip. We see the patient on the right is pointing to that location out on the side, which is usually not due to a problem inside the hip. Instead, that is something we call trochanteric bursitis. It's a very common condition, affects people of all ages. The good news is that it is not a surgical problem. This is an issue where very strong and powerful muscles that help balance your hips, called your abductors, come from your pelvis down to that side of your hip, and those tendons can become irritated for a variety of reasons, usually overactivity or a strain. There's also a bursa that sits beneath those tendons that helps them glide smoothly, and that bursa can get inflamed or irritated, leading to that pain, and patients get trochanteric bursitis. Now, as I said, this is a non-surgical problem, so what can you do about it? Typically, this is a regimen of stretching, ice and heat, occasionally over-the-counter anti-inflammatories, something you can and should see your physician about, but again, not something we would need to do surgery for. Now let's talk about x-rays and what we as orthopedic surgeons look for when you come to our office for a clinical visit. On the left is what I would describe as a normal looking hip joint. We see that the hip is a ball and a socket. It glides smoothly because of cartilage on those surfaces, and cartilage does not show up on x-ray. It is a radiolucent material, and so we see a space in normal, healthy functioning joints. As you can see in that x-ray, we've denoted that as a normal joint space between the ball and the socket. Contrast that with what you see on the right side. In that x-ray, there is joint space narrowing, indicating that the cartilage has worn out, and we now have bone-on-bone arthritis. Cartilage does not have nerve endings, but bone does, and that's why this bone-on-bone phenomenon is so painful for patients. Transitioning to knee x-rays, the same rules apply, but we look for different things because the anatomy is different. So the knee is not a ball and socket joint, but a hinge joint that moves like this. Those blue arrows are pointing to that joint space that is represented by cartilage, and as I said before, on the hip x-rays, cartilage does not show up as a dark substance, and so when we see that space, we tend to think that's more likely a healthy, well-functioning joint. Contrast that with what you see in the x-ray on the right, where this patient has lost their joint space. They now have bone-on-bone arthritis. And I'd also point out to you that one side seems to be worse in this patient than the other. And that's very typical of what we see. 90% of patients have arthritis that is more severe on the inside or the medial side of their knee than the lateral side, and that's the case for this patient. So, if we have joint pain and bad-looking x-rays, what are our options for management to make us feel better? Well, there are several, but I'd like to start with a few rules of thumb. Rule number one is we always, in any area of medicine, and particularly in orthopedic surgery and hip and knee arthritis, we want to start conservative. We want to start with the easiest treatments, because a lot of times these treatments are very effective and we don't need to do something more aggressive, more invasive, more painful. Some of these first-line treatments include things like modifying our activities. Now, that's a statement that you'll hear your doctor say a lot, but it means very broad things. If we know that there's certain activities that stir up our pain, make us feel bad, and we can reasonably avoid them, then we should avoid them. We can also modify our activities by supplementing our gait with things like a cane, a crutch, or a walker to offload these painful joints. We can also do activities that are lower impact. So if you like to walk, or perhaps do a stair stepper or some light weights for exercise, maybe something a little more gentle like an elliptical or cycling or a pool set of exercises is going to be more friendly on your joints, and we encourage all of those things. The next bullet point you see there is to lose weight if possible. It's not a linear relationship between weight loss and stress on your joints. In fact, for every pound of weight loss, you get a factor difference in the decrease on your joints, especially our hips and our knees. So even a couple pounds can make a very big difference in the stress that your joints are experiencing. And as I sort of alluded to just a few seconds ago, low impact exercise is really a very important thing. That keeps our joints healthy and moving. It keeps our muscles around the joints strong so that it can offload them, but also it helps us lose weight to that previous point and take the load off the joints by multiple mechanisms. But then we also need to think about pain relief itself. And so medications such as Tylenol, Advil, these over-the-counter type anti-inflammatories can be very effective, especially in the early stages. When these more conservative modalities have failed, we think about injections as our go-to second line of therapy. There's a variety of different types of injections, and the one that we recommend usually as a first line is corticosteroids or some derivative of the drug cortisone. And as many of you may know, cortisone was in fact discovered here at Mayo Clinic by Drs. Kendall and Hench several decades ago, one of the many legacies of Mayo Clinic and one of the many legacies within the Department of Orthopedics. Steroid injections tend to be effective in about 50% of patients. We don't want to mislead patients that these are effective in everybody, and they tend to be sort of an all or none phenomenon. In patients where it's effective, it tends to be very effective. And then with each subsequent steroid injection, they can lose effectiveness over time, and that's when we start thinking about our third line treatments that I'll be speaking about on the next slide. If steroids are not the preferred option, some other options include hyaluronic acid, which is also known as the rooster comb injection in colloquial circles. Hyaluronic acid is part of our synovial fluid that is in our joints and helps them glide over one another. And if we add some of that substance back, patients will report experiencing some pain relief. These have not shown quite as good of evidence as steroid injections, which is why we usually only use them if steroids have failed. They also tend to be a little bit more expensive. And then increasingly, we are getting questions from patients about regenerative medicine type therapies, usually in the form of platelet-rich plasma or stem cell injections. We don't do this very commonly at Mayo Clinic, as the evidence we have found to date does not suggest that they are very effective at relieving pain in the arthritis population, but they're actively being studied at our center and centers throughout the country and indeed the world. What we usually tell patients is that they're typically not very harmful, so they can be worth a try, but the evidence to date would not suggest a lot of efficacy. They do also tend to be very expensive. Most insurers would not cover this, and it's a hefty out-of-pocket charge, so a buyer beware scenario there. So, as I alluded to, there is a third line option, and this is joint replacement, and what we're really here to talk about today. And that is total hip arthroplasty, and here forward I may refer to that with the acronym THA for total hip arthroplasty, and total knee arthroplasty, or TKA. So everybody wants to know with any procedure, how successful is this procedure? And although I'm biased as I'm in orthopedic surgery, the evidence backs up that these procedures are very successful. By many metrics, they rank as #1 and #2 of all surgeries in all areas of medicine in quality added life years. Medicare in particular cares a lot about that metric of quality added life years, and we should all care about that metric. What we want to do in medicine is add quality to the life that we have to live, and hip and knee replacement certainly do that. THA, in fact, is often called the operation of the century for the 20th century, given the robust change it made in the quality of patients' lives once it was introduced by Sir John Charnley in England in the 1960s. However, these are not perfect surgeries. They occasionally do fail, and when they fail, that's a disappointing outcome, and there are things we can do about it, but it's something important to counsel patients. A nice rule of thumb number to remember is that these procedures fail at an approximate rate of 1% per year. So in the first year after your surgery, you have a 1 in a 100 chance of having that surgery go poorly and needing some sort of revision. And at 20 years, that would mean that you have an 80% chance of a well-functioning joint and a 20% chance of a joint that's not doing so well, or maybe had a problem somewhere along the way. That becomes important when we think about age and how we counsel patients. If a 30-year-old patient needs a joint replacement, which is becoming increasingly needed in our country, that's a different discussion as far as the chances it will fail in your lifetime than if an 85-year-old needs a joint replacement. Not only are these very effective, but they are very, very common procedures. They are some of the most common elective procedures that we perform in the United States today. And as you can see in this graph on the center of the screen, we are undergoing a period of exponential growth for the need of these procedures. Indeed, by the year 2030, only a decade away, it's estimated that 3.5 million knee replacements will be performed in the United States alone every single year. With total hip replacements over 500,000, 572,000 is the estimate per year in the United States alone, and many more worldwide. Now, as we're starting to perform more of these primary joint replacements, failures do occur and these need to be revised. So in addition, these type of revision procedures are undergoing exponential growth. And it's estimated that over 250,000 per year will need to be performed on knee replacements by the year 2030, and nearly 100,000 per year for total hips. Now some of the basics of how a total hip functions and is performed. We are replacing a ball and socket joint, as I referred to earlier, and there are usually 4 pieces that make up a total hip replacement. As you can see in that diagram on the right, we've expanded out the pieces to show you how they work individually. Beginning at the top, there's usually an acetabular cup, some form of liner that's usually made of polyethylene, a femoral head, and a femoral stem and neck that are unitized. Those all go together to give you a piece of metal in your thigh bone, a piece of metal in your pelvis, and usually either a metal or a ceramic ball that articulates with a plastic liner that snaps into that acetabular cup. So an elegant design, several pieces, but in the end they all work together. There are some nuances that are gaining a lot of attention in the press about total hip replacement. In particular, this relates to how the hip is approached. We get patients coming into our clinic all the time asking how surgeon X or surgeon Y does their hip replacement. And there are 3 primary described approaches done in the United States and across the world today. Everybody wants to know which is best, and what I would tell you is that there are very minor pros and cons for each. And indeed, all three of these approaches, an anterior, a lateral, and a posterior, are done at Mayo Clinic by some of the world's expert surgeons. So that tells you right there that these are all very widely accepted, very rational ways to do hip replacement. What I would caution every patient is that much more important than the approach to the hip is who's doing your hip. Are you having it done in a reputable center? Are you having it done by someone you trust? That's what makes the real difference. If we're driving a certain type of truck, it doesn't necessarily matter what color the truck is. It matters who's driving the truck, and if you think that that truck is a high-functioning machine. Another question patients will ask about is, are we going to use cement or not? Now, that is particularly relevant to a more elderly population, as data would suggest that using a cemented component in our thigh bone, our femur, is helpful because it helps avoid the risk of fracture, both at the time of surgery and after surgery. Which is best? Again, there's pros and cons for each, but this is based on bone quality. So when patients have had a fracture and they need a hip replacement, we almost always use cement in that case. If they have poor quality bone from a DEXA scan, a history of osteoporosis, or are more elderly, we're also more likely to use cement in those scenarios to help protect their bone. Transitioning to total knee arthroplasty. These function similarly in that they usually are made up of 4 pieces, but this can range from 2 to 4 pieces that make up the knee replacement. Pointing them out on this pictorial diagram here in the center of your screen, there's usually a metal cap at the end of the thigh bone. We make several cuts to make that metal cap fit perfectly and remove the arthritis. Then there's a piece of plastic in between the thigh bone and the shin bone, and a piece of metal that we unitize with the thigh bone. Lastly, most knee replacements will also have a piece of plastic behind the kneecap to help that glide more smoothly. This is done, I would say, in about 2/3 of cases, but occasionally a surgeon will enter the knee and find that the kneecap looks just fine and leave it alone. So what are some things you need to know before your surgery? The first is that every patient needs a medical checkup. This is really critical. As orthopedic surgeons, we often get so focused on wanting to do the best we can technically for the hip or the knee that we need to really involve our colleagues that have expertise in other areas to make sure that you are as healthy as possible before you undergo this surgery. So a full, comprehensive medical checkup is essential before you think about a hip or a knee replacement. Second, you really need to think about keeping your muscles strong. The more prehabilitation is the term that's gained a lot of popularity recently. The more prehabilitation and muscle strengthening you do before surgery, the more successful you're going to be after surgery. We really think about strengthening the quadriceps, strengthening those hip abductor muscles. That's going to help you get up sooner, start mobilizing, and get you back to your normal life quickly after the surgery. And then it's also important to identify your care resources after the hospital. I suspect that as residents of Charterhouse, that's going to be a much easier transition for you, but we also counsel patients extensively about this when they come in talking to us about surgery, both from the side of the surgeon. We also plug them in with social workers, physical therapists, to talk to them about where they need to go, what family is going to be involved, and how long they may need to be in transitional care facilities. On the day of surgery, a procedure like a hip or a knee replacement typically takes about 1 to 2 hours, but that's not all that's involved. For those of you that have undergone this before or had a family member or a friend undergo it, you know firsthand this is an all-day event. It starts early in the morning. You have nurses take care of many things getting you set up. The anesthesia team has to meet you and get you prepared from that aspect. There's a lot of preparation that goes on in the operating room with the patient before surgery even starts. There's a very lengthy recovery in the post-operative area. And then once you're awake and alert and feeling good, most of the day has gone by. This is a big division of labor. It's a huge team effort. There's no one person that's more important than the other, but it includes the surgical team, anesthesia, our nurses, our therapists. All of us work together to make this a successful day for you and your family. The hospital experience is very important. On the day of surgery, believe it or not, after a big operation like a hip or a knee replacement, at least at Mayo Clinic, and I would say at most places throughout the country, you're getting up and working with a physical therapist that same day. You're getting up, you're walking around, you're learning how to use the walker if you've never used one before, you're eating and drinking. It's really come a long way since even a decade or two ago when that was not the case. In the days after surgery, there's more physical therapy, and most patients leave after 1 to 3 nights in the hospital. And occasionally, patients will leave, believe it or not, on the day of surgery, and that's thanks in large part to the major advances that have occurred over the last several years with anesthesia. When it comes to recovery, I like to talk about the rule of threes. This is something I learned from one of my mentors, Dr. Pagnano, who's the chairman of our department. He counsels patients on the rule of threes, where he talks about in the first 3 days, you're back to doing very simple activities around the house, getting around your house, making some light meals, things of that nature. Within 3 weeks, you're back to doing simple things around town, maybe getting the groceries, running a few errands, very light duties, typically with someone to help you drive. And at 3 months, we expect that the vast majority of patients are going to be back to doing their normal activities that they were doing prior to surgery, but I would still tell patients that they're only 80 to 90% recovered by the 3-month time point. So there's still quite a bit of growth that undergoes that 3-month time point all the way out to a year, which is when we expect most patients to be at their new fully functioning level, their new normal, so to speak, after a joint replacement. Patients always ask if they need physical therapy, a question we get every single day, and I think the short answer is that you usually don't. That doesn't mean that physical therapy doesn't have a role, but I would say that it's not necessary in every patient. For a hip replacement, we almost always say that therapy is not needed, at least on the front end. Walking is by far and away your best rehabilitation and the thing that's going to get you back to functioning at an optimal level. For knee replacement, this is a little more nuanced and quite a bit more surgeon dependent. We have a big goal that we harp on with every patient. We want your knee to bend at least to 90 degrees within a month after surgery, 2 months at the latest, and if that's not the case, we might start to intervene with some more aggressive things. But what we often find is that if we send patients to start working on their range of motion with a therapist specifically right after surgery, they can tend to overdo it and be a little too goal-oriented. More is not always better, and setbacks are common in this setting. And so we want patients to keep the knee range of motion nice and gentle. We see a therapist if things aren't coming along, but if we push it too hard, that can actually be counterproductive. I'd like to sort of wrap today's session up with talking about some recent research that's been done at Mayo Clinic, showing us how we can optimize our outcomes with total joint replacement. And hopefully, if you're considering this, you can think about some of how this applies maybe to your own case. So I've spoken about this multiple times already, but if you can lose weight, that's very, very important. Not only does it offload your joints, but we have shown that with almost every important complication, it is much, much more frequent in patients that are overweight, obese, or super obese. And you can see from these curves, if you're mathematically inclined, they are not linear. They go up sort of exponentially once we get to the higher range of BMI. Now that can be a source of caution, but also a source of encouragement. What that means is, for a very small change in weight, if you're on the very, very high end, you can be on that steep end of the curve and drastically reduce your risk. So even a couple pounds, like I said before, every little bit counts. It's very important to optimize your weight to the degree that's reasonable for you before a joint replacement. Also, know your allergies. This is something that's gaining more frequent attention, something we've done research on here at Mayo Clinic as a team, and where this really comes up in patients that have a documented penicillin allergy in their medical record. We see it all the time. It's usually from childhood that a patient had a rash or something mild of that nature to a penicillin drug or a cousin drug of penicillin. And too often we are quick to say, okay, they had a penicillin allergy, we need to use an alternative to penicillin. And what we found at Mayo Clinic is that that's not necessarily the right thing to do for most patients. This graph can be summarized by saying that the blue line is the drug that we typically use. It's a cousin drug of penicillin at the time of your joint replacement. And the red line is all those other drugs that we go to if someone has a penicillin allergy. And the risk of infection is much higher when we use those alternative drugs. And if patients have a very mild reaction to penicillin, and we could have used that class of medications from the start, that's what we should be doing. So what we found here is that patients that go to our allergy clinic that had a previous history of penicillin allergy, the allergist gives them a clearance to use penicillin products 97% of the time. There's many reasons for this, but it just goes to show that oftentimes getting tested, making sure it's safe, you'll find out that it is safe, and that can really help us as your medical team give you the best care possible. As I alluded to on the previous slide, when we use cefazolin, which is a cousin drug of penicillin, the risk of infection is much, much lower, 32% lower, which is an incredibly steep reduction in risk. So the recommendations we tell everybody: tell your surgeon about your allergies, tell them about the severity, and if there's any concern, get tested with an allergist and see what is safe and not safe for you. Cutting down on pain meds. Everybody hears about this. The opioid epidemic is a true crisis in our country, throughout the world really, but in particular in the United States. This is a huge problem. We know that outcomes are worse for patients by almost every metric when they come in using narcotic pain medication before a joint replacement, or if they have prolonged use after a joint replacement. The government has gotten involved in this, insurance companies, hospital settings. Everybody's putting forth new guidelines. So typically at Mayo Clinic what we do is restrict the number of opioid tablets that we give patients to about 25. We also are restricting refills, and this is not meant to be mean or to not try to treat pain. We definitely want to do that, but we want to do it safely and not put you at risk. We've done research here to show that doctors traditionally have been very bad about predicting how much pain medication patients need. This is a little bit of a busy diagram, but the take-home message from it is that the composite between the blue and the red lines is how much doctors typically prescribe patients opioid medications for specific procedures, but the blue line alone is what most patients consume. So you can see there's a huge mismatch in a lot of cases that we are over-prescribing. So we're doing a lot of research to figure out more patient-specific tailored methods for giving you just the right amount. So some of the take-home points from today's talk are that total knee arthroplasty and total hip arthroplasty are extremely successful procedures for patients with hip or knee pain, secondary most of the time to arthritis. Surgeon and hospital is much more important than the details of what implant that surgeon is using or what technique they're using. Like I said, make sure it's a hospital you trust, a surgeon you trust, and let them decide what's the best implant for you and the best approach for you. This, at the end of the day, is a quality of life decision. It's not an emergency in most cases. It's not life or death, but that doesn't mean it's not important. You're in control. You decide when the pain is bad enough to undergo a big operation, such as a hip or a knee replacement, and this can be really a game changer for you with your pain and your function. Plan on about a 3-month recovery after these type of procedures. This goes back to those rule of threes that I learned from Dr. Pagnano. At 3 months, that's when we expect you to be back living your life as good or better than it was before the surgery. And make sure you advocate for yourself. This goes beyond hip and knee replacement, but definitely applies to hip and knee replacement. Make sure that you've done your research, you have a plan for care after a big surgery like this, and do everything you can to reduce your risks. It's a very successful procedure, as I've said many times today, but bad things can happen. We do see failures, but you have a lot of control over reducing those risks, and we, as your surgical team, do everything we can to reduce those risks as well. So I hope you've enjoyed today's discussion. It's been a highlight for me the 2 times I've had the opportunity to do it. It's a real honor and privilege, and thank you for your time and attention.